All right, I think we're ready to get started. We have an awesome cohort with us, and I know we have more that are trickling on. So to be respectful of everyone's time and to get into this great content, I want to welcome you to our monthly Lunch and Learn series. My name is Alex Huffman. I'm the Assistant Director of Support Services here at the Cancer Center. If you've joined us for these in the past, thanks for spending some more time with us and gaining more information through this awesome ongoing event. If this is your first time, welcome, welcome. And we're so pleased that you can be a part of this and hear from Dr. Zaha, who truly is an expert in this topic. We are recording this webinar, and you will receive a copy of it after the live session today. We also encourage you to put your questions in the chat. We'll be looking at those and be ready at the end of Dr. Zaha's presentation to get into those questions, as many as we can, knowing that we do have a large group. And to that point, if we are not able to get to your questions, Dr. Zaha has very generously agreed to put together an FAQ, a frequently asked questions document, that will live on the website for the Cardiovascular Clinic, and you'll have the ability to access that after the session as well. And just a note on your questions, while we really want to be as helpful as possible in getting into the things that are important to you, we are not able in this session to provide direct medical advice or get into the specifics of your diagnosis. So if you would keep those questions as general as possible while also trying to get what you need from it. And so at this point in time, I'm going to do a quick introduction before I turn it over to Dr. Zaha. Dr. Zaha is an associate professor at UT Southwestern Medical Center here in Dallas. He's a clinical investigator who combines patient-centered clinical cardiac care, multimodality advanced cardiovascular imaging, and cardiometabolic research. Dr. Zaha holds joint appointments in the Cardiology Division, the Department of Internal Medicine, the Advanced Imaging Research Center, the Harold C. Simmons Comprehensive Cancer Center, and the Biomedical Engineering Program in the Graduate School of Biomedical Sciences. He serves as founding director and section chief of cardio-oncology. And on a personal note, Dr. Zaha is originally from Romania. His interests beyond science and medicine include his family, friends, outdoor sports, and the exploration of nature and the arts. So it is my pleasure to welcome Dr. Zaha to our Lunch and Learn series.
Thank you so much for a kind introduction. And can you hear me well? Excellent. So this is very exciting today, and almost as exciting as being in person and meeting everyone here. So I can only imagine everyone behind the screens. It is my pleasure today to present the heart of the matter, insights into cardiovascular health for cancer patients. And thank you, Alex, for this introduction. I have no disclosures, but I will present some scientific data, and therefore I listed here our scientific research support for cardio-oncology projects. So where do we start? We start with survivorship. So why is it important to talk about cardiovascular health in cancer survivorship? It is because with the tremendous progress in cancer diagnosis and cancer treatment, we have numerous stories of success around the world and from our patients into what means long-term survivorship and reaching the other end of treatment. And these are some highlights of hope, courage, caring for your heart, and beating the odds in the course of this treatment. However, cardiovascular disease remains the world's #1 killer. And cancer treatment has been so successful that now we have to think upfront about cardiovascular health when cancer treatment starts. And focusing on the right side of this panel here, is important to realize that the cancer survivors have 5-6-fold higher cardiovascular risks, which are presented here. High blood pressure, unhealthy diet, high cholesterol, diabetes, overweight and obesity, tobacco, air pollution, kidney disease, physical inactivity, harmful use of alcohol. They are all modifiable. So this is amounting to probably more than 50% of the risk of developing cardiovascular disease. So it is important to acknowledge and to address these risks. And in addition to that, It may be surprising for some, but all these are also shared risks with cancer, and that being cancer progression and cancer recurrence. So with this in mind, I prepared a set of slides that is aiming to address a few questions in 3 major sections. What is cardio-oncology? What are cardiovascular risks of treatments for cancer? And maybe most important, what will happen at a possible visit with a cardio-oncologist and what to ask the clinical team? So I will try to unpack a little bit these questions and be ready to address some of your questions. So first of all, what is cardio-oncology? Many times we are asked about this. What is this? Is the heart developing cancer, or what are we focusing on? Well, sometimes it is called cardio-oncology. Sometimes it is called oncocardiology. It is a bridging discipline that has as its main goal to minimize the cardiovascular toxicity while maximizing anti-cancer effects. So what we do, we help the hematologists and oncologists to use the medications in the safest way to maximize the anti-cancer benefit. And how do we do this? So we are aiming to close the gap between 2 major disciplines: cardiovascular health and oncology, hematology. And many times patients unfortunately fall in between, both in trials, where many of the cardiovascular trials do not include patients with active cancer, and the other way around. Oncological trials do not include patients with cardiovascular risks. Preventing cardiac damage, this is a major point because a lot of the care can be prevented in this space. Recognizing early cardiotoxicity, while everybody is being treated for cancer and many patients are successfully treated, cardiotoxicity is not entirely predictable, and therefore early recognition and early management is important. And the goal is overall to improve the overall outcome. So ultimately, thinking about the long-term outlook for many patients in the situation, it is important to come on the other side without cancer and with a healthy heart. So thinking, who needs to see a cardio-oncologist? That would include upfront patients who are going to receive high-risk cancer therapy, and I will have a few examples in the next few slides. Patients who already have heart or vascular problems and require treatment for cancer, considering that in this group, even cancer treatments that have lower risks can result in an unstable cardiovascular system, at least during those treatment cycles. And I would say not the least, the cancer survivors. And thinking here about survivorship as being a marker of having the cancer diagnosed and the cancer treatment started, because there is a high chance of a long-term remission or complete resolution of the cancer nowadays. What if I already have a cardiologist? So let's say that I have a cardiovascular problem that is known, that is being treated. So then I would ask cardiologists whether they are familiar with the cancer treatments that are going to be used. And then what are the heart or vascular related side effects of those treatments? Or what is the effect of the cardiovascular treatments or cardiovascular conditions on the oncology treatments? So I think if the answer to those questions, to either of those questions is unclear, then you may consider including a cardio-oncologist in your team, at least while getting the cancer treatment. And it may not come as a surprise for patients to be referred to cardio-oncologists when they have a specialist in this area that they can access. So what are the treatments that cause cardiovascular toxicity, and what means cardiovascular toxicity? And I'll list here a few items just to recognize them by name. I realize that many times we use jargon in our all the medical language. So then just recognizing what we may be referring to. So coronary artery disease or vasospasm, when the blood vessels are tightening up, electrical changes such as QT prolongation, hypertension, which is quite prevalent in the population, arterial and venous thrombus can be caused by cancer treatments, pericardial effusion or fluid around the heart. Atrial fibrillation is also a common manifestation. And one of the most recognized is cardiotoxicity, where the heart muscle is suffering due to the cancer treatments. And this is the iceberg paradigm, where most of the well-established treatments, such as antimetabolites or chemotherapy, for example, anthracyclines or 5-fluorouracil or radiation therapy, are well recognized by now for causing cardiotoxicity. But new therapies and combination of multiple therapies, such as hormonal therapies, molecularly targeted therapies, and multiple novel immuno-oncological therapies, including bone marrow transplant, immune checkpoint inhibitors, genetically engineered cells such as CAR-T or bispecific antibodies, are increasingly recognized to cause different types of cardiovascular toxicities depending on the combination of treatment, on the duration of treatment, depending on the other problems that the patients may have. So recognizing here that all the cardiovascular components can potentially be affected by one or other treatment, and that all the different classes of current state-of-the-art hematology or oncology treatments can affect the cardiovascular system. So what are globally, what are the risks for the cardiovascular system? And on a background of important component of social determinants of health, it is clear that the risks are intersecting between cancer and heart disease. There are some cancer-specific risks related to treatment or cancer type, some of which I have already mentioned. And there are some specific heart disease risks related to congenital heart disease or genetics or underlying problems that are already established. But in the center, there are many risks that can be that are intersecting, and some of them are genetic, and we can detect them, but maybe not address them directly yet. And the list below includes several of the modifiable risk factors that I mentioned earlier, such as smoking, obesity, hyperlipidemia, sedentarism, diabetes, and hypertension. So if we can take all those away, then the risks are significantly reduced. So now, if we look at all the different types of cancer treatments and thinking they can cause a different type of cardiovascular toxicity, I would like to present an overview of how can we approach this. So how can we recognize, diagnose the cardiovascular toxicity? I'll say in a classic way, thinking about the symptoms that the patients would present with is one way to do that, right? So thinking about chest pain, shortness of breath, palpitations, fatigue, swelling in the ankles. Those would be some signs that are recognized, but they may come late. And then how do we define if these are related or not related to the cardiovascular system? So we have blood tests, we call them blood biomarkers. We have different imaging modalities that we can use. We are using electrocardiograms or more sophisticated monitoring and connected to the electronic health records using wearable devices nowadays. Many patients would have an Apple Watch or a Fitbit or other wearable devices that will track their pulse rate, rhythm, and give them input about the circadian rhythm and the quality of their sleep. So those are all elements that can be then integrated and increasingly so using machine learning and artificial intelligence tools that are emerging as a guidance modality potentially in the future. So at what time can we use all these modalities, and do we have to use that in everybody? Of course, we do not plan to use that across the board, but we can also guide ourselves depending on the risk profile that I will detail further, and target the pre-treatment stage, look during the treatment if any complications arise, or after treatment for potential long-term or latent complications of cancer treatments. So now focusing on how to prevent cardiovascular risks long-term, starting from the modifiable risk factors. So we reviewed that many of them can be controlled, can be addressed, and that significantly decreases the risk. We can optimize the care for existing heart and vascular diseases. This is further decreasing the risk. We can apply strategies to minimize cardiovascular toxicity, and this is the partnership, a close partnership with hematologists and oncologists. So we talk a lot about different situations where there's an opportunity to minimize the risk. And I would say not the least, by detecting and managing the earliest toxicity signs that we can identify, and then allowing for the treatments for cancer to continue. So with this, at this point, we can follow established guidelines. And this is an example. It's a complicated slide. I'll try to break it down a little bit from the current guidelines that are in place since 2022 from an international body that has reached the consensus, so both in Europe and internationally. And they apply at different stages. So thinking about the time point 0 as being the new cancer diagnosis, the evaluation of the risk profile is important to happen at all stages. So going from the starting point at diagnosis, the patients are evaluated and classified into based on their baseline cardiovascular risk and the toxicity risk assessment of their treatment. So there will be low risk patients, moderate risk patients, and high and very high risk patients. So based on this, focusing on the low risk patients, for the most part, the standard surveillance that is happening within the general clinics is sufficient. It is mostly based on symptoms and signs of change, which would be rare in that case. But in case of moderate risk and high and very high risk patients, a referral to cardiology or cardio-oncology specifically is important. And it can help make a difference in the way the patients would be feeling, and their outcomes during the oncological treatment. Another time point that is, again, important to keep in mind is the first year after cancer treatment. So thinking that most treatments are going to be completed, or some treatments may be continuing, but at that point, all the intense initial phase is potentially successful. Knowing what is the state of the cardiovascular system and what are the long-term prevention approaches is a great opportunity that first year. And then not the least, long-term. And I mentioned earlier latent or late cardiovascular toxicity. Unfortunately, that happens. And there are potential changes in the immune response in the body with activation of atherosclerotic plaque. And then there are also potential changes in the heart function on the long run. Again, many of them are preventable at an early stage. So, therefore, it is important to keep an eye on the cardiovascular function even after completion of the cancer therapies. And I would say not the least, and to keep in mind, is if any of those symptoms and signs that I mentioned earlier, such as chest pain, palpitations, shortness of breath, fatigue, ankle swelling are showing up at any point during or after the cancer treatment, a referral to a cardio-oncologist is a reasonable approach. So with that, I'm going to present here a few more points regarding the risk, because the scientific discovery doesn't stop there, and there are opportunities to be able to engage early on at different levels. For example, learning more about the experience of patients. So we are listening and we are learning from our patients. And we have initiated community-based research projects that are allowing us to improve the care through this mechanism. Also, we have initiated the utilization of AI technology, exploring how we can use AI technology in a well-guided way to support decisions and to support communication with patients. And I would say not the least here, one of my areas of interest, and I'll try to show a couple data there, is the earliest point of detection of changes in heart function at a stage that is reversible, where the energetic the energy production and utilization in the heart can now be detected and potentially intervened upon before cardiovascular disease progresses. So regarding our community-based project, I would like to highlight here the long-term goal to address health disparities in cancer survivors. And considering the gap between these highly specialized areas in medicine, cardiovascular care and oncological care, the special place of cancer survivors is, in fact, a position of disparity, because many times there is a focus on the cardiovascular side, but there is a miss on the cancer side, or the other way around. Specifically in this project, our objectives are to create a system that will be very easy to apply to estimate the 10-year risk of heart attack or stroke in a broad population, to survey the knowledge and preferences for learning health and medical information in patients, and to understand better how we can assess and support the needs, the motivation and engagement for patients to increase their awareness of cardiovascular risks and benefits from preventing those risks. So we have created a series of lectures that have been facilitated by our community partner, Ms. Shayla Petterson, and by fellows from our cardiovascular medicine and oncology programs, and also organized health fairs where we have helped patients to get updated measurements of their blood pressure, prostate-specific antigen, lipid testing. And we have also partnered with the National Network with a 50 Hoops organization to provide information, and both live and virtual, for patients in this space. And here is an example of some of our successful outreach events where we had numerous patients engage with us and get updated on their preventive measures, and then recommendations to follow up with their clinicians when needed. In another project that and here, for who is for anyone interested, we can also bring this link to a survey that provides a multidimensional approach to better understand the knowledge in this space, and also to think about the preferences to learn health information, and also what would be the level of engagement in preventive care. So if you'd like to use this link, you're welcome to do so. And if you have any questions, please contact us. So the second project that I would like to highlight here is partnering with AI resources. And this is an initiative that involves a network of cardiologists and cardiologists with a special focus at the cardio-oncology intersection around the country to create what we call a cardio-oncology passport, which would bring in the hands of patients a tool to track their oncological treatments and diagnosis, and be able to share that information directly with cardiology and cardio-oncology specialists, bringing together their oncology and hematology partners in communication about risks that can be then facilitated also by an AI-powered system. And not the least, I mentioned that I would be showing some images of heart energy utilization, and we are working on a project that is trying to move upstream on the cascade of detecting early the changes in the heart before there are, for example, changes in perfusion or changes with the scarring of the myocardium or irreversible heart failure. We are learning about these modalities in monitoring patients who receive toxic treatments such as anthracyclines. And using the information that we learn, we will be able to apply it further, more broadly, in cardiovascular diseases such as congenital heart disease or genetic cardiomyopathies, infiltrative cardiomyopathy such as amyloid, inflammatory cardiomyopathy such as sarcoid, ischemic heart disease, pulmonary hypertension that affects the right ventricle, and more broadly, heart failure. And in the current era, where everybody is aware that the metabolic therapies for multiple systems are increasing in utilization, it is very appealing to be able to use such a technology. And I would say this is not isolated to the cardiovascular system. The same metabolic investigations are happening in cancer, and they are giving early markers of successful treatments. So I would use here and call to action: long live metabolism. It is one area that is evolving and developing in science. These are examples of using substrates that can be detected in cardiac MRI. On the left-hand side, the presence of the substrate that we inject in the cardiac chambers. And then on the right-hand side, this ring of signal is the heart muscle that is using the substrate pyruvate, which is a metabolite of glucose, showing that this is a healthy heart that is using chemical energy effectively. And this is a project where we are looking in detail at all these signals, and we are continuing this work at UT Southwestern. So again, if you have any questions here, you can reach us directly by email. And not the least, I would say the part that maybe if we can boil down all the questions that I was trying to address today in 3 questions. So if you are at your clinic visit and if you are asking how might the cancer treatment impact the heart and the cardiovascular health, I think that would be probably a good point to bring in discussion, considering the long-term potential benefits. Another question might be, what can we do to minimize the risk of cardiovascular complications during and after cancer treatment? as I was pointing regarding the multiple modifiable risk factors that are available. And not the least, maybe a reminder about specific signs and symptoms of cardiovascular issues that someone should be watching for during cancer treatment. Now, it is fatigue or shortness of breath and decreased physical activity are happening often during cancer treatments. But one point that is important, and I realize from many patients, is that most people are not aware that exercise is actually good during cancer treatment, and it helps on the long run. And there are more and more studies now coming up showing that also the recurrence of cancer and the overall outcomes are going to be impacted by exercise. So there is a favorable effect of that. So with all that, I hope that you are all going to win the race and maybe share with us your winning snapshots from your race as one of our patients. And I would like to acknowledge here the entire team that has helped us to develop this project. And I would also like to thank everyone who continues to support our team. And you can see also the large cardiovascular medicine team that we are in contact with constantly to help everyone get the necessary cardiovascular care in time and not to have to interrupt their cancer treatments. So with this, thank you so much for your attention, and I'm happy to take any questions.
Thank you so much, Dr. Zaha. And the questions are coming in, and if you still have one and have not had a chance to put that in the chat, now is the best time to do it. So we'll kick off with the first one, which is a question about some guidance around magnesium. Can you speak a little bit about recommendations on taking magnesium with cardiac ramifications?
Okay, excellent. That is a good question. I would say maybe 3 points about magnesium. It is an electrolyte that has a pretty quick fluctuation in the blood pool. Therefore, measurements are sometimes variable from one blood draw to another. The second, it is important to have magnesium within the normal range because of the implications on the electrical activity of the heart. So with that, if it is found to be decreased, you may receive some magnesium supplements. A challenge may be, depending on the supplements that are used, related to the GI issues, right? And with the bowel transit that sometimes can happen if with some higher doses of magnesium. But overall, keeping it in the right range will help patients, especially with the QT prolongation that I mentioned earlier. So that's important to keep in check.
Thank you, Dr. Zaha. The next question is about, and you did touch on this, about radiation and chemo. But this question is specific to radiation and Temodar. Is there more you'd like to say about the specific risk with that combination?
So the risks are, I would say, especially related to the amount of radiation that is touching the heart. And there are a lot of efforts of planning. And if you think about the planning phase that involves adjusting the breathing, for example, and adjusting the timing of the radiation dose to a part of the breathing cycle to take the heart out of the field. I think that's probably going to be the most important. And I think while there are effects of radiation combined with the chemotherapy, for example, on the tumor, right? What we try to do here is to take the heart out of the radiation field. Temodar is not in itself increasing significantly the cardiovascular effects, but I would say that's a different question if there's a high dose of radiation touching the heart.
Thank you. This next question is really interesting about women's heart health issues. What are the percentages of increased heart issues due to decreasing women's estrogen levels? And the follow-up question there is there any evidence of more women having heart issues at a younger age due to being put in menopause at a younger age with some of our cancer treatments?
Excellent. So there are definitely changes that are happening across the board, right? And I think um, in this sort of broader context of different types of treatments that can be happening, there is a compounded effect of the hormonal changes and the other toxicities on the system. So thinking here about the vasculature, thinking about the heart muscle, I think those are the main areas that we have to consider. And I would also acknowledge that we don't know everything now about how all those hormonal changes are happening, and you may hear different responses to that. So it is an area that is being actively investigated, and it is important to come a little bit closer beyond just a broad clinical arena into what are the specific mechanisms at cellular level and what types of cells are going to be effective the most. For sure, we know that all the hormonal interventions are not coming without their own risks. So that's something that's acknowledged. And maybe to highlight some of the top potential concerns on the long term there would be that of blood clots that can be influenced by sex hormones, and that of progression of atherosclerotic disease and of something that we call the metabolic syndrome.
So the same question for our male patients would be any connection with hormone therapies in prostate cancer and cardiac risk?
Definitely. So that is another area. So both for men and for women, perturbance in sex hormones has cardiovascular risks, and they are on the spectrum that relates to the heart function, the vascular function, the electrical activity of the heart, especially in men, and therefore preventive measures and the referral for preventive evaluation in patients who are going to receive androgen deprivation therapy is important. And long-term prevention with healthy diet and exercise are going to be key elements that we emphasize in preventive education.
I think that leads to a question I'll jump to, also on stress management. Cancer treatment is very stressful alone, and many patients are taking Xanax or antidepressants and anxiety medications. Any relationship there between those medications and cardiovascular risk?
That is an excellent question. It is important to realize that the cancer treatments are part of a broad cocktail of treatments that need to be happening at the same time. And for example, the medications used to control the nausea can be affecting the electrical system and can induce something we call QT prolongation in technical terms, which is an electrical change in the heart that increases the risk of arrhythmias. Now, some of the antidepressant medications and medications for anxiety can do the same. And by that, the more medications are combined from those classes, potentially the higher the risk of causing arrhythmias. So I think the balance there is quite delicate. The one factor that helps there is indeed physical activity, exercise, and it doesn't have to be very strenuous, just increased aerobic activity. It can be just walking and having that scheduled, which may help also with psychological improvement during the treatment. And sometimes having a psychologist on the team, right? So having a combined team that will have all the partners going from dietitian, exercise oncology, psychologist, think those are key elements, right, to keep that balance during the intense time of cancer treatment.
Thank you. Absolutely. And to that point, we are trying to expand our programs that we can offer patients in this line. So we do have currently a mind body based yoga class. We have an art class as well as meditation. So some of the things you can add to your standard of care to help with that stress management. Dr. Zaha, the next question's here on overall screening. What is the cardiac screener that's kind of standard of care for this, including lipid panels? How often should things like that be in a patient's care plan?
Excellent. So so clearly those slides that were referring to the baseline testing, I think they are raising some interest. So before starting cancer treatment, having an evaluation either by your family practitioner or by the hematology and oncology clinic in partnership with the general practitioner of the risk profile would be the best approach, right? So that way, all the metabolic changes can be factored into the risk profile. And if there is if there are any symptoms at that point of shortness of breath, chest pain, palpitation, fatigue, even before starting the cancer treatments, that is the moment to be able to engage. The timeline for follow-up then will depend, right? So it depends on what is identified. And if there is an initial evaluation that raises concern of at least moderate risk profile, right? Or maybe high risk profile, then an upfront referral to cardio-oncology will be necessary. And it will be a combination of probably blood work and some imaging tests, maybe a stress test that may give us different types of information regarding cardiovascular health and how to manage that along with the cancer treatment.
I think this is a great piggyback question. How quickly should an at-risk patient be seen by a cardio-oncologist? You just kind of referred to that, but maybe to expand on that, to answer, how can providers assist patients with this process?
Excellent. So maybe this has two questions in it. So maybe can we split them, right? So one of them was, so how can their providers help them to reach a cardio-oncologist? And I think we are happy to engage with the providers depending on the timeline that is needed. And sometimes we can see the patients the same day or the next day if there's something imminent that's coming up. If it is something that's planned a little bit farther ahead, then that gives a little bit more time. And usually in regarding the cardiovascular system, an immediate assessment is more to confirm if we are going to be able to negotiate a significant risk, right? So where we have to balance the risk of starting an intense oncological treatment regimen, right, without having reached the full balance of the cardiovascular risks. So I think that is probably not the optimal approach. The best is to be able to have sufficient time. So I would say the sooner the risk is assessed as being increased, the better to be in contact with the cardio-oncology team. So we have different mechanisms to do that, ranging from visits in person, telehealth visits for patients who are farther away from Dallas, or sometimes electronic consults where we can get all the data provided to us and transferred electronically to be able to engage directly with the providers.
So this is a kind of continuation of that. So now that a patient has been monitored for several years, for example, maybe they're 5 years out of cancer treatment and have had echocardiograms along the way, when the results come back as within normal limits, can you speak to kind of what that may mean, and if it means there is a possibility of weakening, but can still be in what we would term normal?
That's correct. And we usually have a process we call shared decision, right? So we discuss those results with the patients and then place them in the context of their stage in long-term survivorship. And sometimes we see a trend of changes. For example, if somebody was treated for cancer at a young age, maybe less than 10 years of age, and then 20, 30 years later, there will be some changes, right, in their cardiovascular system. The goal is to maintain the function. Sometimes we cannot reverse time, right? So we would not be able to bring it back all to where it was before the cancer treatment. But the goal is to make sure that the trend or the weakening that you mentioned in the heart function is not progressing rapidly. The relative change from one visit to another gives also us a sense of how soon do we need to have that follow-up. And sometimes patients at lower risk would have a follow-up at 5 years. And if everything looks good there, then probably the next timeline would be similar. But if we see any signs of heart weakening, then we would probably either intervene with starting a medical therapy or watching closer to define if that change was transitory or is following in the same direction.
And very similarly question here, for a cancer treatment that restricts blood vessel development and results in higher blood pressure, how long would it take for something like that to resolve? And would it be expected they would go back to prior levels?
Excellent. I think there are probably two scenarios there, and somebody is very knowledgeable about those effects, which I can tell you it is something that's happening quite frequently with our patients. So we have discussions about maybe just a little bit more than just the surface and what it means, because everybody lives with those treatments. The one possible scenario is that the treatment is going to be stopped, right? And then clearly there are effects of those medications that are going to stop there. But if the cancer was treated, right, there is no more need for that cancer medication. So then there will be reversal of those processes. I would say sometimes though, the cancer treatment cannot be stopped, right? And those medications will still be on board. And in that case, what we're aiming for is a balance between or a counterbalance, right? Between the effects of those medications and how can we support the cardiovascular system while maintaining good control of the tumor growth.
Okay, lots of questions coming in still. One question, Dr. Zaha, could you speak to a little bit about where your clinic is located and how patients may request a referral?
Absolutely. So I think we both have here this background. It's almost like we are in front of the building. So this is the Cancer Center outpatient building on the UT Southwestern campus. And you may access this link on or the QR code here on the page. And that would be a good way to get in contact with our clinic. So we see patients from everywhere in the Metroplex and beyond. So at this point, I think we learned quite a bit from COVID, and many patients have several visits a year to UT Southwestern for their oncological care, and that's a good moment to combine the visits and potentially have cardio-oncological evaluation if it's required.
And if a patient was not treated at UT Southwestern for their oncology diagnosis, could they still have a referral to the cardio-oncology clinic?
Absolutely, and we have several patients who are in different stages. I think it is important to acknowledge that the cancer trials can be happening in different centers, and there are different opportunities to get the best cancer treatment at different times. UT Southwestern has a large number of trials that are currently running, and I think we see a lot of patients going through those. But if patients would be enrolled elsewhere in another trial that may not be available, we are definitely happy to see them no matter at what institution they get their care.
Wonderful. Let's see here. We have a question specific to a patient that may have both a cancer diagnosis, gone through chemotherapy, and sarcoidosis. Can this lead to fluid on the heart?
It may. Yeah, the answer is may. I think it is, as you're mentioning, it's quite specific in that case. And maybe the patient who answered, or the family member who answered, who addressed that question, may need to reach back to their clinical provider and maybe ask for a referral. We can definitely help them. We have imaging modalities specific for sarcoidosis, and that is important, and it can be managed in parallel to the management for cancer, and by that provide the best outcome.
And this is a great qualifying question for you. Does a cardio-oncologist only focus on the heart, or also veins, arteries that could be damaged from chemo and radiation?
Excellent. So yes, thinking here more broadly about the cardiovascular system, right? We would include the heart, the veins, the arteries, the different structures in the heart. For example, the valves, right? The conduction system in the heart. So we are helping the patients being a gateway, even, right, for the other specialized areas in cardiovascular medicine, and identify what is the problem. Will the patients require an advanced intervention, for example, for addressing a valve issue, right? Or will they need a vascular procedure where our colleagues in the vascular center will be helping? So we are connected with all the other specialists in cardiovascular medicine, so we can address all those specific questions.
Okay, and I think we have time for a couple more. Here's another one that will trip me up, I'm sure, in pronouncing it. But what is radiation vasculopathy?
Okay, excellent. The reason I introduced, I wanted to introduce here the fact that some treatments can have not only heart toxicity, but toxicity to the blood vessels. So the vasculopathy is just it's a jargon term for vascular damage due to radiation. And radiation is a very powerful tool and is used successfully in many cancers. But as any of our treatments, it comes with a potential downside, right? And any other structures that are coming in the way of the radiation field can be potentially damaged or aged. The element that is important for the cardiovascular system is faster aging, and that is recognized as a potential mechanism for the damage that is happening late after the radiation treatment.
This next question is specific to the implant, the Watchman. Is that proving safe and effective in lieu of blood thinners when surgery or after surgery?
Excellent. That is a very good question. We employ that in patients who are going to require treatments for cancer for long term, with potential to affect their platelet count or blood clotting. What is also a point that we discuss with the patients, though, is that in the early phase after the Watchman device placement, and just to outline what that means, it is a device that is placed inside the heart and block the formation of clots in a certain part of the heart, which is called the left atrial appendage, so to decrease the risk of stroke. But immediately after placing that device, patients still need to be on blood thinners. So it's not a solution for everyone, but it is a safe solution. It always requires a careful assessment of the risks and benefits of applying it. So it's not universal, but it is a useful approach.
Okay, and this next question circles us back to exercise. Sometimes exercise is challenging after you have some of the side effects following treatment. Could you speak a little bit about how we might be able to find more creative ways to increase cardio when maybe physically we can't do some of the ready to go type cardio exercises?
This is an excellent question, and I have to acknowledge here our exercise oncology team, with whom we are partnering to improve the exercise level for patients, no matter at what stage they are during their treatment. So sometimes we use exercise as a preparation phase before a big surgery, because we know that there will be a loss of ability to stay active physically following immediately that surgery. And we encourage patients to stay active during their treatments while gauging what is their perceived level of effort. So it's better to put some effort, which might be then just a simple walk, a walk in the park for a few minutes, which may feel at a moderate level for the patients, while before that they were just able to either climb stairs or jog or do something else, but they may have to decrease the intensity of the activity as much as they still perceive it as being moderate. So the goal here is not to push to the extreme during that time, but not to stop all the way. So it's better to have a bout of exercise of a few minutes in the day, and if feeling tired after that, take a nap, right? But that cycle of still engaging the system will be favorable. And many times the effort capacity will be also variable during the treatment cycles, right? So if there is a treatment cycles of 3 weeks, maybe not to push too hard during the early part when it is the most difficult, but then catch up during the downside of the cycle. And then overall, that tone will be maintained, and the recovery after all the treatments will be faster.
Okay, I think we can sneak one last question in, and this goes back to our conversation on supplements. What are your thoughts on CoQ10, PQQ, and Arugina supplements?
Okay, those are very specific questions, and I think I will have to defer this answer to the oncologist and hematologist, because what is important to realize that any supplements are, just because they are supplements, they may intersect and interfere with some of the medications, right? So I think it is important to put that in the context of the oncological treatment plan. And also, if the patients are receiving any cardiovascular medications, that is also specific discussion that we would need to have.
Okay, well, that brings us right to 1 o'clock. Thank you guys so much for your engagement and participation in today's Lunch and Learn. Thank you, Dr. Zaha, for such an informative hour. And again, Dr. Zaha has offered to look at the questions that we have not yet gotten to and revisit those that were frequently asked and develop a page on their website that you'll be able to reference in the future. And all the recording and that will also be sent to you by email after this live session today. So thank you so much for joining us, and we hope you have a great weekend.
Thank you, everyone.